I'm Sunny Hatch. I'm a faculty scholar in the John P. McGovern Academy of Oslerian Medicine. And today I'll be discussing Aequanimitas with Dr. Jack Alprin and Dr. Judith Aronson, who are both emeritus scholars within the Academy, and a student scholar, Jacob Moran. So, Jack, could you provide us a historical perspective on Dr. Osler's medical career, providing us some background to this seminal address, Aequanimitas, and when he left Pennsylvania?
When he left Pennsylvania, yes, that's right. This was a commencement address. These young men had graduated. I don't think there were any women in that class. They were young men, graduated, now going out and practice medicine. And he is giving them some advice on what would be of help to them to maintain their stability as physicians, to maintain their sanity as physicians. They've got to be cool. And he was telling them what they've got to do, what's involved in maintaining their cool. That's what commencement addresses are all about. Mm-hmm. Giving the class some final instructions on how they should behave as they go out into life.
Do you think you can give us a historical background?
Well, yes, I can. Osler was born in 1849. July the 12th, we always celebrate that year at the Academy every year, the annual oration. At the age of 16, he left school, left home, and he went to Toronto, where he entered the Trinity College School, which was a college preparatory academy. And that the next year, in 1867, he entered the Trinity University College. And when he went off to school, they thought that he would pursue a career as a minister. His father was an Anglican minister, so his family thought that he would become a minister as well. But he got involved in biology. He was introduced to the microscope, which makes me very happy. I love microscopy. Me too. Judy likes microscopy, yes. He was introduced to the microscope, and that led him to the study of biology. Mm-hmm. And he met a physician, a Dr. James Bovell, who was practicing in Toronto and who was also a teacher at the Trinity College University. And Bovell got him interested in practice of medicine rather than becoming a minister. And so Osler then enrolled in the Toronto School of Medicine in 1868, I guess. That was a proprietary medical school. We don't have them anymore. Actually, that's not true. I think there was now a proprietary medical school in LA, California. There's one. But at that time, they were very common. He recognized very quickly that the quality of instruction was not very good. And he heard about this other medical school in Montreal called McGill. So he was able to enroll in McGill. And I guess he spent 3 years in McGill and graduated in 1872. He then spent 2 years in Europe, which was a common practice at that time for someone who graduated from medical school in the North American continent to spend some time in Europe, if at all possible, to visit the large medical centers there. So he spent some time in Europe, spent some time in London with Sanderson. That's where he pursued his studies of blood cells. That's where he demonstrated that there's a small cell in the blood called platelet. He also spent time in Berlin. He had an opportunity to spend some time studying with Virchow, the father of pathology, and spent some time in Vienna, meeting Hebra, the father of dermatology, and Rokitansky, another famous pathologist. Then he came back to Canada, Montreal, and was on the faculty of McGill starting in 1872. if I'm correct about that. 1874, I guess. And then he was at McGill for 10 years, and that's where he started developing the Osler legend, I guess. He was apparently he had to lecture, but he proved to be not a very good lecturer, so he had to learn how to lecture, had to teach himself how to lecture, and he became a very good lecturer. He had a small practice. He because he needed money to help keep him alive, he took on the job as taking care of the poor and the sick at Montreal General Hospital, where they had a large number of patients with smallpox. He took care of these indigent patients who had smallpox. He probably acquired a case of smallpox himself, but he survived that. Okay. He became a good friend of the students. He was the registrar for McGill for a while, and became in that capacity. He met all the students, and I gather he had a good relationship with those students. Okay. And then in 1884, I guess, he then left McGill and went to Philadelphia, University of Pennsylvania, as professor of medicine. He continued his studies on pathology there, and then at the end of his time at Philadelphia, that's when he gave this famous address entitled Equanimitas on May the 1st of 1889, I think, graduation. So that was his background up to the time this address was made.
So, Judy, why do you think he chose this as his farewell address?
Wow, that's a great question. I was kind of wondering about that as I read it. I do want to preface my remarks by saying how much I enjoyed reading the essay again. It had been some time since I read it, and every time I read it, I get something else from it. So why did he give this set of what I think is pretty rich advice to his audience that he was leaving the University of Pennsylvania? I don't know. I was wondering if it's partly because he just cared a lot about trainees and colleagues and wanted to give them life advice that would help them in their careers. It's kind of a parting thing. I think people always, almost like a commencement address, you want to give advice. It sounded to me like he was using it as an occasion to kind of, in a way, honor the memory of Samuel Gross, that he just died recently. I couldn't tell.
Yeah.
And then the other thing that intrigued me was it was a chance for him to reflect on his own mentor, Palmer Howard, with great affection. And I thought that last bit was an interesting thing because here he was exhorting people to be cool and calm and imperturbable. And he was, I think, expressing some grief at the loss of those two people. So he even said at the end, you know, I'm kind of telling you all these things, but I'm not such a good practitioner myself. That's the way I read it. I don't know what the others would think about that.
You know, when you get off the elevator in the academy, the first thing that hits you in the floor is the emblem, right? It's embedded in the floor. And Aequanimitas is in that emblem. So the term has become to epitomize Osler and his teachings. So Osler is revered as the ideal physician, and as you discussed, he's bringing forward in this particular speech anyway, and some of his behaviors is obviously modeled by this, is his ability to be with someone at the bedside and who has a devastating illness, but at the same time have equilibrium in what's going on with his own personal life. For instance, you just gave us two examples just then. And you're right, this essay brings out two terms, not just equanimitas or equanimity as we would call it today, but also imperturbability. So how did Osler define imperturbability? He defines it as coolness and presence of mind under all circumstances, and clearness of judgment in moments of great peril, immobility, and impassiveness. And so last year, we were at the oration meeting, and we were sitting next to each other at the dinner, and you engaged me in a conversation of this very topic. you said, "So, what do you think about Equanimitas?" And it's like, okay. But, I gave you some examples in my career as an oncologist, but then you expanded how that fits in your life, in your career. And you're head of the autopsy services here. And I never in my life would have thought of Equanimitas under those circumstances. But you shared with me then, and I'd like for you to talk amongst us, if you don't mind, about your experiences. And the patient is obviously gone that's in front of you. But yet you're dealing with the support group, or even the lack of the support group, of the individual that's there with you.
Yeah, I've given some thought to this. Obviously, in my practice, I aspire to be imperturbable in the face of people's grief and sometimes anger. It's less about the physical suffering of the person and the uncertainty of what's going to happen to the person, but it's more about dealing with the family members and the close friends' grief and all the ways it expresses itself. So sometimes and I would say this is not infrequent, when a family member, this is often a parent of a child who's died, an adult child who's died, will call me up ostensibly to talk about autopsy results. And what happens is they tell me stories about the decedent. They ask me questions that I can't answer, that are really not answerable. Sometimes I try to answer some medical or pathological questions, but mostly it's just them wanting to talk about their dead loved one. And many, many times this is a conversation full of what I would call grace and humility. There's one, I get goosebumps when I think about this one. There's a woman in her 60s whose son died in a motorcycle accident. I did the autopsy and she called me about results. And after we talked about it, she said, this is a woman who just lost her son. She said to me, I want to thank you for what you do. And I just thought, how can this woman have the generousness of spirit to thank me? I just did a postmortem exam on her son. That really stuck with me, that kind of largeness of spirit of some bereaved members. On the other hand, sometimes the family's reaction is not that ideal, and this really resonated with me in reading the essay. I think one of the things I got out of reading Aequanimitas this time is that Osler talks about you have to have patience with your fellow man, because sometimes fellow man does not live up to our expectations of them, and we need to be humble because sometimes we're just the same as them. So I have occasions where someone has died and the family members contact me because they suspect that the girlfriend has poisoned the elderly father, or there's all kind of family dynamics, which I find to be sometimes a little bit unpleasant or seedy or unseemly. And so I'm going to remind myself of Osler's words next time that happens. And finally, I just wanted to say, in terms of my experience of this, that one of the things Osler talks about a lot is having equanimity in the face of uncertainty, that you have to have kind of a calmness even when we don't know the answers. And that happens to me sometimes when family members want to know what happened, what caused this disease, and I can't say with certitude, and that makes me very uncomfortable. And so how can I convey a sense of comfort and closure when I have uncertainty about the biomedical aspects? And then, of course, we all have uncertainty about our own mortality. I mean, in some ways, I face my own mortality every day in my practice and dealing with family members. So that's kind of how I'm interpreting Equanimitas in the context of my own practice.
And of course, you mentioned imperturbability. Osler defines imperturbability as coolness and presence of mind under all circumstances, clearness of judgment in moments of great peril, immobility, and impassiveness. Imperturbability, though, is defined as not being capable of excitement with the connotation of serenity and calmness. But Jacob, does that mean that a physician should not become emotionally involved or affected by the individual that they're under their care. So of interest is that I have found you to be someone who's very passionate about your work at St. Vincent's. Could you tell us a little bit about that clinic and your role there and some of the patient interactions that you've had there?
Sure. So I've been at St. Vincent's for probably about 6.5 years now, and I've enjoyed most of it. But serving patients at a clinic who are coming for free care because they don't have health insurance or because they lack the coverage that they need to get the care that they need, has been challenging in many aspects. It's challenging because patients come in and we have a lot of questions we have to answer. Do you have food to eat? Do you have transportation to get here? There's this whole slew of problems that come along with their health care. And, in general, talking to a patient is an incredible thing. To be vulnerable with somebody and ask them some of the hardest questions that you can ask somebody so you can learn what's going on is just a great experience. And I love that part. And I love being able to connect emotionally with a patient who is really suffering in many different ways. But what makes it challenging is figuring out those social things, trying to manage more than their health care. And I think when we talk about imperturbability, it's very easy for students who don't have a lot of experience to feel overwhelmed. All of a sudden, we have somebody in front of us who doesn't have anything, and they're asking us to take care of their health. They can't drive to the pharmacy. If they get to the pharmacy, they're not going to be able to afford their medicines. If we ask them to take their medicine with food, we don't know if they'll have food. So there are all these things that we have to manage, and it can be very tough for students. But I think that as students volunteer at our clinic, they become more and more experienced with understanding what are the resources available. And I think that as you grow in your knowledge and understanding, you start to develop this sense of imperturbability. You understand that, okay, here's a need, and although there are 10 other needs, I know how to address this one. So let me start there, and once I've addressed that, we can start working on these others. And so working at the clinic has been wonderful. Being able to just serve people who are in need, who don't have any other resources. But it has been challenging to learn what are the resources I can offer, and how can that allow me to have kind of a calmness and a presence with the patient while I'm talking to them.
So what happens when you go home? Do you take it home with you?
I've been there for a while, and so the first couple of years I mostly saw patients, and I loved that. I loved it so much. In my second year of medical school, I think I followed about 18 patients that were my patients. I saw them every few months, and we had this connection, and that was wonderful. And then I started moving more into a leadership role and more administration. And while seeing patients, not much came home with me. I knew what I needed to do for the patient, and I wrapped things up at clinic. When I stepped into that leadership role, I started to see that there are 30 students that are doing what I was trying to do, and they didn't all have the answers. And so there are lots of places where we are missing things, and patients are potentially suffering harm because we're not catching things in time. And that, to me, started to kind of weigh on me. There are these small decisions that, to us, are small. Can I change a patient's appointment to next week because we're overbooked? But for them, maybe they spent a month trying to find a ride to come to the clinic. And a lot of those seemingly small decisions started to weigh on me. I think over time, I hope that I haven't become calloused to that sense of some of the decisions we make as providers really impact our patients. But I do think that I have maybe a calmness now of it's not the end of the world. We can figure out how to get them into the clinic. And if they need help with transportation or whatever it may be, we can help them with that. So I don't have to worry about every small decision. It's important to try to find systemic solutions to those problems, but I don't have to have everything weigh on me alone, absolutely. But in general, there are ways that we can work around the problems.
I would think that would be hard to separate if you're at the bedside of somebody and you're trying to work a strategy for discharge, for instance, and you're having to weigh those types of problems. And it would be easy to be frustrated, I would think, with so many barriers.
Absolutely. And I think, many things can come to mind, especially when you're working with patients who don't have much to offer. But something that helps me is to make that emotional connection with the patient, be vulnerable and ask. I'm about to prescribe you this medicine. It's going to cost you $15 a month. Is that okay for you? Or do we need to look at other options? And so that burden doesn't all need to be on me. I can share it with the patient and ask them, what's best for you? This is what I want to offer, but it might not be best.
May I say something regarding the term imperturbability? How does one acquire this? I'm going to give you my take on this from my perspective as a physician sitting at the bedside of a patient or in the clinic. I think to achieve imperturbability, the physician has to have a thorough understanding of medicine, must understand diseases and how diseases behave, understand the pathophysiology of the disease, but also understand how it affects the patient, how the patient may respond to that illness. And when you achieve, and the achieving this then allows the physician, one, to be able to answer patients' questions when questions are asked. But at the same time, when some sudden event takes place, some acute problem arises, and the physician has to react quickly. Having a thorough knowledge of disease helps to create that imperturbability so that they can carry out whatever is necessary to take care of the problem. So this is my view of what is here. I don't know if this is what Osler was thinking, but this is how I view this. You got to keep your cool dealing with patients, and to answer their questions or to deal with them in acute episodes. This requires studying medicine very intensely. You got to have a thorough understanding of medicine, and that becomes more and more difficult today. It was easier in Osler's day because they didn't know as much. Today, you have to know a hell of a lot more, and it's a more difficult thing to achieve, I think.
As a hematologist, you're often at the bedside and you're called in late at night, and you're dealing with often a patient in crisis.
That happens sometimes. That is true, and I've got to deal with that. I got to go in and see the patient. But if I have an understanding of what's happening, of the background of the patient's illness and the problem, I think that helps me help them at that particular critical time in their life.
So Osler's use of the term immobility is compatible with the definition of stability. And in medical context, it signifies that the physician should not be swayed, as you mentioned, from concise medical judgment, right? And we have to temper that with emotional involvement, especially when the patient's in distress. And I know you've been faced with that as well. But Osler did not advocate that equanimity take precedence over medical science, but that it be dependent in part upon the scientific knowledge, right? So basically what Dr. Alpern has mentioned to us, just to be confident in the fund of knowledge will help us and offset losing your cool.
That's right.
Okay. So Dr. Erickson, you're involved in medical education. Is it essential that this is a characteristic that we should look for in future physicians?
That's a good question. I think it is. Even Osler had some discussion about to what degree is that characteristic ingrained or innate, and what degree can it be taught. I do think that our selection process should select for students who are capable of developing, dare I say, imperturbability or equanimitas. How do you recognize that in someone who's relatively young? People are trying to figure out how to do that. I have no idea how to do that. But I do think that Osler teaches us that the characteristic of equanimitas includes both the competence in medical knowledge and fund of knowledge that Jacob and Jack so eloquently talked about, but also a real knowledge of human beings. And to me, I don't think Osler ever used the word compassion in this essay, but he used the word understanding of fellow man, appreciating fellow man, infinite patience towards fellow man. And to me, that's the other aspect that you have to, and I think Jacob talked about, both of Jacob and Jack, my colleagues, talked about having a very solid fund of knowledge and a lot of experience, but also the capacity to appreciate what the patient is going through and why they might react in certain ways. That's, I think, the hard part to assessing people, but I do think that's a selection criterion we should have for medical students.
I agree. I think that what you're mentioning is that students should have some kind of capacity to care for others. We've got to look for that in medical students. I think there's this trend toward wanting students to do really well on their standardized exams, and students sense that pressure, and so I think a lot of students focus on that, but we really have to look at, do you have the capacity to care for the patients that you're going to be treating? I think that's so important, and I think that is a key component to imperturbability and equanimitas, is this idea that not only do I have the fund of knowledge, which if we're talking about whether somebody can be taught equanimity, I think certainly you can gain more knowledge and experience along the way, but whether or not you're able to use that knowledge and experience to care for somebody else is a huge question, and I think it comes back to maybe that's something that we should look for in our students, and maybe that's something that can't necessarily be taught.
Should it be a medical school course? Should it be a dedicated medical school course?
Teaching how to care, I would hope that people coming to medical school wanting to be doctors have a sense of caring for others. If we can teach it, maybe so, maybe in some aspects. Should it be a course? I think so. I think you've got to help students develop their sense of care and compassion for others. I think if we're only focusing on scientific knowledge, we're kind of missing a key aspect of what it means to be a physician. And so I think making space in the...
I absolutely agree with Jacob, but I think if we created a separate course called caring, it would seem like a separate course like biochemistry, which is it's a thing you do in this little space and time. It's not a thing you carry for you. So I think it should be embedded throughout. And I think there have been efforts to do that curricularly, and sometimes we call it professionalism, which to me is a word that has become such a buzzword that it's kind of lost some meaning almost. But I think by giving students an opportunity to reflect on their interactions with patients, what it means to them, not biomedically, but personally, their emotional reactions, to talk about that with their colleagues and with physician mentors could help in that. I do think that there are some people who are just perhaps not capable of developing it to the degree that you would want for a physician, and maybe they're better suited for another career. But I do think it can be developed, and I do agree with Jacob that that should be emphasized as much in a curriculum, emphasized and assessed as much as we emphasize and assess biomedical knowledge. Biomedical knowledge has become not a gateway. The idea of the licensure exams is that you are competent to practice, not that there's a difference between a 232 and a 231 on a board exam, but that you can master the huge medical knowledge fund that Jack and Jacob talk about. But it's not meant to discriminate between people. What we should do is use that as a gateway and then help people develop their skills of bedside manner, compassion, professionalism, caring, whatever you want to call it, my opinion.
Let me make a comment. I agree with Judy that there shouldn't be a course that says imperturbability. These are things that should be woven in throughout the entire curriculum. But I've always said that the big part of what's involved in becoming a physician as a person who deals with people, a big part of that should have been acquired sitting in their mother's lap or standing at their father's knee. They should have gotten this growing up. Now, in an age when single parent families are more common, this may be more. This is harder to. This becomes a more difficult problem, I guess. But these are things you should bring to medical school with you. Some fundamental ideas about how to deal with people, how to relate to people, how to treat them. And you can't teach it, but you can learn it over time.
You deal with residents, and of course you do as well, and in addition to fellows rotating through your service and med students rotating on your service. Do you feel that their rotations should be limited to clinical faculty that model this behavior?
Ideally, that'd be a good thing. If there are a lot of faculty who do model that, that would be the best way to do it. But I'm not so sure in our school anyway, that that's always possible. We have a large number of students that we have to process, as it were, every year. And many times they're assigned to faculty who just happen to be occupying a particular, being assigned to a particular ward service. The doctors assigned to that ward service, we feel, are very capable physicians, but how well they can impart some of their knowledge to students is another story. Mm-hmm. What you're asking for, I think, would be ideal, but I don't know how practical it is, how well it could be achieved.
Judy brought up a good point, compassion. Compassion is something that I think everyone at this table anyway feels is very important in the interactions with their patients. But it's not specifically addressed in this particular essay. Why do you think that?
Well, I would actually argue he addresses it obliquely. Mm-hmm. I think when he talks about having infinite patience with your fellow man, understanding where people are coming from, I think that is compassion. Why he doesn't use the word compassion, I don't know. I don't know if it was common in the vocabulary at the time. I don't know if it would have been common in the vocabulary of Christian leadership that he grew up in with a minister as a father. But it is interesting that the word is not used. I also think he's perhaps focusing more on the inner life of the practitioner, on how to help them develop calmness and imperturbability. I did it, and Aequanimitas, rather than on the outward expressions of compassion. But I have no idea.
I think I agree with Dr. Aronson. I think this is probably an address more focused on what's going on with you. How do you manage yourself so that you can care better for your patients? And so I think he probably is not focusing on that interaction. And if he were, he may emphasize more how to be compassionate and caring for your patient. I think he's here talking a little bit more about self-care and development, and how that will then influence how you treat your patients.
So it sounds like we're dealing with the C's when we deal with Aequanimitas. There's coolness, right? Calmness. We want to be collected and clear of thought and clear of judgment. But I think this table, anyway, for this discussion, we would add compassion. Do you agree?
Sure. I think Judy is correct when she said it's implied in this lecture, although he doesn't use the word. But everything he talks about is compassion, one form or another.
And I think Jacob's comments are really insightful. That he's he's talking about the characteristics you have to inculcate in yourself in order to display compassion. That's brilliant. I'm going to quote you on that.
Thank you for listening to this perspective on Oslerian essay, Aequanimitas. It seems that Osler was certainly pertinent in the past. He continues to be pertinent in the present and hopefully will be in the future as well. So thank you again for your attention to this discussion. And as always, practice medicine with your head, your heart, and your hands.
UTMB Health, working together to work wonders.